But when you start doing ClinChecks with deep bites, just like my open bite case, they're gonna start to look ugly. And you have to make them ugly on purpose. Not because you like ugly ClinChecks. Because you want good orthodontics, so your ClinCheck has to look like the orthodontics you used to do. And then your orthodontics will look like the orthodontics you used to do. But if you order pretty ClinChecks, what you're doing is you're putting in soft, straight wires. And if you put in soft, straight wires on certain cases, it could get you into a little trouble. Now, in a case like this, if I put soft, straight wires, I won't be in so much trouble. Let's talk about case selection with aligner orthodontics and overbites. He has 100 and whatever, 10% deep overbite in the anterior. He's a growing teen. He's had 2 consults that told him he's not a good Invisalign candidate. I look at him and I know he's an ideal Invisalign candidate. What do I have going for me in case selection? Well, I have a few good things. One, he has a normal face height. He's not brachycephalic overclosed, so he doesn't have hugely strong masseters. 2, he has a lot of lower crowding. So when you have a lot of lower crowding, and if those teeth are retroclined to begin with, and you feel comfortable to be able to allow them to come forward, and he has good gingival health, as they come forward, you get relative intrusion. Everybody still with me? That makes him a good candidate. But here's probably the thing I like the most about his candidacy for deep bite treatment with aligners. When I'm intruding 4 incisors, what is the first tooth that I'm going to look to for anchorage to intrude the 4 incisors? The lower cuspid, because it's the first tooth that might have an attachment on it that stands there, says, I have an attachment, lower incisors, you come down. If you don't hear your teeth talking like this to each other in your ClinCheck, you should be drinking more. So, attachment, UTs, come down. But sometimes you get an overbite, and the patient, the cuspid, is part of the anterior overbite. The cuspid is up there in 100% deep bite too. And now you have to intrude the cuspid too. And if you have to intrude the cuspid too, you now have a big, long, rooted tooth, and it makes your case much more difficult. So sometimes people come to me and they go, would you treat an aligner case with 110% overbite? And I go, I don't like your question. People probably don't ask me a lot of questions because I never, like everything they ask, I go, I don't like your question. The reason I don't like the question is because you're just giving me one factor. I need to know where the cuspids are. Do you see how his cuspids are not involved in the deep bite? So if you imagine a ClinCheck and you kind of have an attachment on the cuspid, attachment on the bi, and an attachment on the bi, you get to level that arch better. Agreed? Because you have now 3 attachments to intrude incisors. Do you remember the case? I even intruded incisors and molars with 3 attachments. So the cuspid is a good friend of yours in this case. Now he plays the trumpet. He was very happy to get aligners, and I want to teach you something else about this deep bite. I know you're not going to see the ClinCheck, and you're going to be happy with me because you won't see the ClinCheck, but you'll see what I mean in a minute. So he wears his aligners. He has treatment. Now in the middle of the treatment, I have a small posterior open bite, where in the beginning I didn't. Does everybody see the small posterior open bite? Stick with me. Hopefully, we're going to have enough time to talk about posterior open bites because they're a part and part. But what you have to do in your posterior open bites is differential diagnosis of your posterior open bite. There's 2 main reasons you can get a posterior open bite. 3. 1, the patient keeps biting on aligners and has transient posterior intrusion. And it'll go away when they stop biting on aligners all the time. Okay, that's the simple one, and he's in that category. 2, this is the hard one. If you don't create enough intrusion, I'm going to be showing you that later, so just listen to it for a minute. If you don't create enough decoupling in the front teeth and enough leveling of the curvus B, your patient can end up with anterior interferences to the original vertical dimension of occlusion. And if they have anterior interferences to the original vertical dimension of occlusion, they're rotated their mandible down and back. And they're often more class 2 than they started. We're going to show you pictures of that, so just wait for a minute on that one. The last reason you can get a posterior open bite in aligners is that if you do a lot of expansion in the posterior, and the ClinCheck is showing you molars moving bodily, expanding, but you're not getting that bodily movement. You're getting tipping. When a tooth tips, it's at the occlusal plane, and when it tips, it comes off the occlusal plane. That becomes problematic. So be careful of that. Now, I know, and I coach people on individual cases, so I can't right now solve all those problems for you on all your individual cases, because in your head, some of you are nodding going, yeah, what do you do about that? But the answer to your question, and your question is different, because I got to look at your case to see what happened and get you out of the mud. There's always a way out of the mud, but it is very individual. So let's watch this case. He goes through and he wears his aligners. And at the end of treatment, you might even say, I still have a little bit of opening between some of the molars. Willie, how can you finish like that? That's not a good finish. You should get another ClinCheck and try to erupt his molars together. Now, I ask you, if you have to erupt molars together, the best thing to do is not have them biting on plastic all day long. So I just give him his lower wire retainer glued only at the 3s. He gets upper aligner retainer that he wears only at night, and 8 months later, when I see him in retention, this is where the teeth are. Because they're not biting on aligners all day long, they can erupt together again. Now, some of you are thinking, but if he's wearing his retainer, how could the teeth erupt together? Don't retainers stop teeth from moving? Orthodontist to orthodontists, my saying to my patients is, retainers don't stop teeth from moving. They limit future movement. Nothing stops your teeth from moving. If a patient says to me, I never want my teeth to move again, you know what I tell them? Take them out and put them on the counter. And now they're never going to move again. You want to live with them? They're going to move. And we can limit it, but we cannot stop it. And if you teach your patients these lessons, and you teach them that by doing orthodontics, you haven't changed their genetics, you create a partner in retention. Because the worst thing for me as an orthodontist is to have my patient think I'm responsible for their retainers the rest of their life.